I'm Mark Schlissel. I'm the Dean of the Biological Sciences, and on behalf of my colleagues in the college, I'd like to welcome you to this final event of this year's On the Same Page series. Each year, we attempt to introduce our new students to our academic community by providing them with a shared intellectual experience, and this year's topic has been a series of discussions and panels on the topic of personalized medicine. This is supported by generous donors to the Letters in Science Leadership Fund. It's co-sponsored by the QB3 Institute, Quantitative Biochemistry, Biophysics, and Bioengineering. And this evening in particular, we'd like to thank the New York Times, who is providing both sponsorship and then also the moderator of today's series. The moderator of our panel this evening is Amy Harmon. Amy received her undergraduate education at the University of Michigan, where she graduated in 1990 with a degree in American cultures. While at Michigan, she wrote for the Michigan Daily, the university's newspaper, that launched her into a career first working for the Los Angeles Times in their Detroit bureau, then moving on to Los Angeles, where she established a beat writing about digital technology as a social and business phenomenon. In 1997, Amy moved to the New York Times, where her career has been nothing short of meteoric. What she does is she writes personal stories to explain to people in a narrative form the nature of changing technology in our society and its impact. She shared a Pulitzer-Prize in 2001 for a contribution to a series on race relations, focusing on an African-American and a Caucasian high-tech entrepreneur. But most recently, and the reason we invited her to join us today, is Amy won a Pulitzer Prize in 2008 for her series in the New York Times called The DNA Age, using stories about individuals affected by emerging genetic technologies as both an educational vehicle and as well as a way to get people thinking and talking and discussing very important issues surrounding the coming era where DNA will be a part of everyday medicine. Amy will be moderating a panel where a number of the folks she's written about in various articles will be here as well as others, and I'll allow her to introduce them to you as well. So welcome, Amy. Thank you very much for coming to Berkeley.
Thank you, Mark, and thanks to all of you for coming. I was asked to come here tonight as a speaker, not as a reporter. I don't have my notepad. I'm not planning to write a story off of tonight's events. This freshman seminar of Berkeley's that you're all participating in, after all, has already received plenty of media attention. As the PR people say, usually when they're looking for a euphemism for not entirely all good publicity. My role here is to introduce our great group of panelists and to moderate their discussion. However, I am a reporter, and asking questions, if you'll pardon the metaphor, is in my DNA. So, before we start, let me just ask you the question that I've been wondering ever since I heard that the Berkeley program was getting criticized by bioethicists and state regulators, and that the university was not going to be allowed to give individual students the results of their DNA tests. How many of you, well, actually, I have to ask you, so how many of you in the audience are first-year students here? Can I just have a show of hands? Okay, so a few. So we're going to have a small sample, but it's still, I'll call it legitimate. So, and how many of those who are here sent in their spit kits when you got them in the mail? Okay. Most of those who are, okay. And so, now, obviously, you all know the traits that you are being tested for: lactose intolerance, alcohol metabolism, and folic acid metabolism. And you've heard by now the objections to the program. Some people felt that you should have a doctor to explain the results of the test to you. Some people felt you should be worried about what might become of your DNA if Berkeley didn't really dispose of it the way they said they would. Some people thought the lab the university was using might make a mistake. So what I would like to know is, now that you're familiar with the criticism and the objections, how many of you are glad that you didn't get your individual test results back? Okay. There's no pressure here. We're on the same page, but we're off the record. So You can, okay. So, and how many of you wish you had been able to get the individual results of your test? Okay, so we have a small sample, but I think it's unanimous actually that everybody wishes that they still had that they actually had their test results. So, I would want them in thinking through what you've been through and what my interest in this. And I think that since I'm not, as I mentioned, not writing about this here tonight as a journalist, I can venture to offer what may sound vaguely like an opinion, which journalists are usually not really supposed to have. But to me, this controversy kind of missed the point, which is not to say that critics didn't raise some valid concerns, but to focus on this issue of how you get your information about your genes, whether it's through a doctor or through the mail, to focus on the real but remote possibilities of a privacy breach or an inaccurate test, is to miss what seems to me to be the main point about this kind of genetic information that is increasingly becoming available to us, which is that genetic information, not all of it, but a lot of it, can have serious, lasting personal and social consequences, no matter how it is delivered, no matter if its privacy is left completely intact. Genetic information can change the way we see ourselves, our families, and our future. And if I understand it correctly, that's just what the Berkeley faculty who organized this program hoped to provoke you into talking about, by sort of getting your genetic feet wet with tests that had very minimal risk and medical impact. But it also seems to me that it's possible that in explaining how unrisky and unrevelatory the particular tests they offered you are, especially when they were put on the defensive, the effect may have been to downplay the potentially profound impact of genetic testing in general. So I think that we're here tonight because Dr. Schlissel and others wanted to be sure that this wasn't overlooked. And I know that many of you have attended classes and other seminars and panels over the course of this month with the same goal. And you've heard from geneticists and bioethicists and sociologists, and some of you may even have read the books that Professor Ryan gave out at the end of his keynote address. But to me, it's always most compelling to go to the source. And we're incredibly lucky to have here tonight Katharine Moser, Deb Lindner, and Anna Tague, all people whose lives have been significantly changed by the results of a genetic test. You guys should come up. Come on up. Katie, Deb is over here on Skype, and Stephen too. I was incredibly lucky that Katie and Deb were willing to sort of open up their lives to me when I was writing some articles in an effort to help me understand the effect of the particular test they took on them so that I could try to communicate that to others. And Anna is part of a group of parents that I got to spend time with as I tried to understand the new bonds being formed between families who are not genetically related, but whose children share a common genetic disorder. I'm going to introduce each of these women by showing you a short video clip. But first, I also want to introduce our fourth panelist, Dr. Stephen Schonholz, who I haven't written about, but who has taken a keen interest in Berkeley's On the Same Page program ever since he first learned about it, and really wanted to come here and share some of his personal experiences with you. Dr. Schonholz is the medical director at Mercy Medical Center's Breast Care Center in Springfield, Massachusetts. He uses genetic testing extensively in his practice and also teaches other doctors how to do it. So he's going to give us a frontline perspective on how genetic testing is changing the practice of medicine. Okay, so we're going to try this video thing, which may or may not have sound. But as I'm sure you all know, since the Times is your main source of news and you go to its website multiple times a day, we do video now with a lot of our stories. And these videos were produced, they ran in conjunction with the stories that I wrote that ran in 2007. So let me just try to get, so this is, okay. So the first one is going to show Deb Lindner, who's over there in real life, and she's here in 2007. And I met Deb when she was a medical resident at Northwestern, and who has since gone on to be an OBGYN in a private practice in Chicago. Deb had, about a year before this video, tested positive for the BRCA1 gene that gave her a very elevated chance of developing breast cancer at some point in her life. And this is just going to be a short clip to show you sort of where she was at this point in time. Are we able to hear it? Yeah?
Finding the lump in her breast.
After a year of research, she began by scheduling frequent mammograms and MRIs, but she lived in constant dread of one day finding the lump in her breasts. After a year of researching and soul-searching, she called her mother with a plan.
She had come to the point when she needed to face this head-on, and that she had decided to go ahead with planning for the prophylactic mastectomy.
She was probably the most questioning, and are you really sure that you want to do that? And are you sure you want to do it now?
Is it not possible to prolong this a little longer, give herself a chance to find that special person, to be married, to have her family, to nurse her babies?
And I asked her if she would go back through my family tree and find out the ages with which people were diagnosed with breast cancer.
And when I went back through the family tree, I realized one of my cousins was 33 when she had her first bout with breast cancer. Deb is 33.
Okay, so Deb can tell you more about that in a minute, but next I'm going to just show a little clip of Katharine Moser, who, when I met her, was working as an occupational therapist at a nursing home in Manhattan called Terence Cardinal Cook, which was one of the few nursing homes that has a ward for Huntington's disease patients. Katie has tested positive for the gene mutation that causes Huntington's. And I'm showing you this particular clip both to introduce you to Katie and also to show you a little bit about what Huntington's looks like and where Katie was working when she first began to confront this. The symptoms usually begin to set in around middle age. Some are learning that they have a higher risk of breast cancer. Others may detect a risk of early onset Alzheimer's. How will this knowledge affect the way we think about ourselves and our lives?
It was shocking.
For Katharine Moser, a DNA test provided a glimpse of the future that was particularly sobering.
But I always told myself that there was a chance.
Ms. Moser, who goes by Katie, is a 25-year-old occupational therapist at Terence Cardinal Cook Healthcare Center in Manhattan.
Mashed potatoes and chicken with gravy.
2 years ago, Katie decided to undergo a genetic test to determine whether she carried a rare mutation in her DNA that causes Huntington's disease.
My grandfather had Huntington's disease. He lived in Cardinal Cook from 1992 to 2002. I remember him before he moved into Cardinal Cook, and I remember coming back to visit, and I actually hated coming here.
The test came back positive, which meant that she had inherited the defective gene that had killed her grandfather. The news forced upon Ms. Moser a new way of looking at her life.
I think I've tried to make myself even more aware of what it is and what I can do to help.
Huntington's disease is a degenerative neurological disorder that affects some 30,000 Americans, and whose symptoms lead to devastating physical and mental impairment.
Huntington's disease is not curable, and it's not really treatable.
Dr. Nancy Wexler is a professor at the Columbia Medical School and president of the Hereditary Disease Foundation.
Huntington's really gets you where you live. It causes these uncontrollable movements. Your face is in constant motion. Your hands, it just completely envelops your body. People also have very severe cognitive disorders.
Huntington's can strike at virtually any age, but most people who carry the disease-causing gene begin to show symptoms around the age of 40. Okay, so we'll hear more about that from Katie, but I'm just going to show you one more very short clip to explain a little bit about Anna's situation. Both Huntington's and the kind of breast cancer that Deb is at risk for are inherited. Your disease depends on what genes your parents carry and which copy gets passed on to you. Anna's 6-year-old daughter, Nicole, has a genetic disorder that for a long time was classified only as 22q13, which is a code for the coordinates on the 22nd chromosome where the gene is part of the gene is deleted, because it was too rare to even have a name. And this disorder comes from a spontaneous mutation in the egg or sperm that makes a particular baby. So I hope that's clear. It's not something that is carried in either the mother's or father's DNA. It's not something that families know about and have sort of grappled with for generations. It comes as kind of a bolt out of the blue. And here we're going to see a girl who's about Nicole's age. Her name is Kyrie, and we were visiting her at her home in Michigan because her parents, for the first time, were going to get a visit from another set of parents whose older son had the same condition.
Families. Historically, we've been able to look at the packages that our genetic material comes in, called chromosomes, 1 through 20. We literally use our eyes to be able to look at that, and we look at these striped or banding patterns on the chromosomes, and that was how we originally found things like Down syndrome. With this new technology, we're able to magnify certain regions, actually the entire genome, and be able to see missing or extra pieces at high resolution.
High fives.
For thousands of children like Kyrie, seeing these exact tiny chromosomal abnormalities means the difference between an incorrect or vague classification of cerebral palsy, autism, or mental retardation versus a certain diagnosis, like 22q13. Numbers and letters signifying the exact coordinates of Kyrie's deleted genetic material.
These are not brand new disorders. These actually have been out there. We have just classified them incorrectly. So we've called them cerebral palsy when in fact it had nothing to do with the baby not getting enough oxygen at birth. It had to do with this genetic alteration.
For Kyrie and most newly diagnosed children, these mutations are spontaneous and not inherited from their parents.
It was a relief that we have a diagnosis, and it explains a lot, but at the same time there's still a lot of questions for Kyrie's future.
Suddenly, we're in this new frontier in terms of being able to define all sorts of new genetic syndromes or genetic alterations. You're the first person to be described with a certain type of disorder. You're the one leading the pack in all of this.
Can you do it?
Okay. Can we just close this? Okay. Can we make this on? Is it on? It is on. Okay. So enough introductions. I just want to ask each of you to talk a little bit more about your situation. And Katie, I'll ask you to go first to sort of catch us up, because that was 2007. And also just tell us, how this information has impacted your life.
Hi, I'm Katie Moser. I tested positive in 2005 for the gene for Huntington's disease, and agreed to do the article. Back before 2007, nobody really talked about Huntington's disease in their family. It was kind of like a taboo subject. My family did not speak about it. My grandfather was sick since I was a kid. He went into the nursing home in 1992 and passed away in 2002. And my mother's one of 6. There's 13 grandchildren, and we never talked about it. I knew the name Huntington's disease, and I did all of the research on my own to find out what exactly it was, and I found out that I was at risk, and I wanted my life to be different. So after college, when I started working at the nursing home, I talked to somebody about testing, and I went and got tested. Coming out with it in the New York Times was quite the experience. And I talked about it with friends. I told my job. I started volunteering with the Huntington's Disease Society of America. But for me, testing overall has been a very positive experience. And, even though there was nothing that I could do about the disease, I've kind of tried to do something about creating awareness and getting other people to talk about it as well. So that's what I've done since.
Okay, thanks. So we're going to go to Deb, who I should have explained is at home in Chicago. She couldn't be here tonight, but she is Skyped in. This is very high-tech, successful high-tech situation. So Deb, can you just tell us also a little bit about how the test has affected you and catch us up on what's been happening since the video?
Absolutely. And Amy, can you hear me okay?
Yeah, we can hear you great.
Okay. Well, Amy, you asked us each to say what was the most striking effect of the testing. And I have to say, probably the most striking thing to me is not its effect on me, but the effect that your article had on the culture in the United States as it pertains to hereditary breast and ovarian cancer. Since the article came out, there have been some incredible changes in the way the American public looks at hereditary breast and ovarian cancer. Shortly after the article was written, it was amazing to see what happened in the press. For example, one of my favorite things, I say that tongue-in-cheek, was when Bill O'Reilly talked about me on his news show and stated that he thought maybe I should have my brain removed because I clearly wasn't using it. That kind of a comment was fascinating to me because as a physician, I knew why I had made my choice, and I understood all the ins and outs of why that was the best choice for me. But clearly the American public and a lot of the more conservative media didn't understand that. Since that time, it has been incredible to watch the changes that have taken place. Not only have there been several celebrities like Christina Applegate who've come out about their own hereditary breast and ovarian cancer genes and about their surgical decisions, but even as recently as last month, Congress actually passed a bill to deem the last week of September National Hereditary Breast and Ovarian Cancer Week. And in fact, there's a day in that week that was deemed National Pre-Vivor Day to raise awareness for hereditary breast and ovarian cancer. And I have to admit, I think the biggest reason that there's been such a change in the public perception of hereditary cancer really stems back to the article that Amy wrote in the New York Times. So that's kind of the landscape in the US that has changed since the article came out. But I think personally, there's been a lot that has changed. And I have to admit, when you ask the most striking change that's happened, I have to say everything in my life has changed since that time. The genetic test itself didn't reveal a lot about me that wasn't already there. The gene that I carried didn't change the day I found out about it. But I think that knowing the result of the test changed the way I perceived myself and how I handled the results. Really, I think, showed to a large degree who I am as a person. It changed my relationships. It showed me who my true friends and who my support system were. It changed my priorities in dating. The person who I was dating at the time really didn't have the kind of qualities and character traits that I wanted in a person. And knowing those test results really sort of magnified that and allowed me to make some incredible decisions and marry the person that I'm with today. It also changed my professional life. At the time, I had just graduated from a residency in obstetrics and gynecology, and I really was able to gear my focus in my career toward people who were at high risk. And I now spend a good quarter of my professional life diagnosing, treating, and counseling women who are high risk for genetic syndromes. I now spend a lot of time educating other physicians. I just finished doing a grand rounds lecture last week at a large university obstetrics and gynecological center where I spoke to the incoming residents about genetic disorders and about testing for genetic disorders. So I think in many ways it's changed my professional life. But not only did it change my personal life and my professional life, it also changed my extracurricular activities. And the things that I have become involved with, the things that are important to me, have really become revolved around this disorder. And I have been able to be a founding board member for a nonprofit called Bright Pink, which helps young women who are at high risk to be educated, supported, and have a sense of community. I'm on the advisory panel for the Chicago Center for Jewish Genetic Disorders, and we provide genetic testing for young people who are at high risk for genetic disorders. And I've even been able to spend some time writing several editions of an educational manual called The Little Bright Book that helps young high-risk women understand what this disorder could mean to them. So when you ask what has changed, I think everything, and everything for the better.
Wow. Thank you, Deb. I think Deb gives too much credit to the New York Times article, but it's nice to know that. I mean, and I guess maybe it's worth talking about, what fueled me to write that article, which was just how much I was hearing from the community of people who were at risk, and which has a really, I think, unusually organized bunch of women and maybe Stephen, actually, you could talk a little bit about, Deb used a term previvor, which has come to mean, someone who is not a breast cancer survivor, but someone who is at risk for the cancer and who, considers herself to be predisposed, who is predisposed to the cancer, and so has to decide how to use that information. And you deal with a lot of women like that, and to also talk to doctors about how to deal with women like that.
Right. What we wind up doing is we have a breast center, and instead of identifying women that come in with breast and ovarian cancer, what we wind up doing is any woman that comes into the breast center, we evaluate their family history as to whether or not they're high risk. And on that day that they come in, whether or not it may be for an infection or a rash or discharge, nipple discharge, or breast pain, we will test them that day if they have risk factors. Now, one of the important things that we realize, and particularly teaching physicians, is that this has really become the standard of care. Whether you're a general surgeon, whether you're an internal medicine, a medical oncologist, OBGYN, it is now expected of you to be able to identify people that are at high risk. And the way we do that is with family history. Now, the interesting thing about family history, when somebody comes into a medical practice, well, the first thing they do is they fill out a medical history form. And part of that means, well, what medical problems do you have? Do you have high blood pressure? Do you have heart disease? Do you have kidney failure? Do you have thyroid problems? And you check off the box. Then you put down, what medications do you have? Well, God, on my thyroid medication, give me the name, give me the amount, how many days you take it, how many times a day do you have? All right, I spend time doing that. All right, now the next thing I want to know is what surgery have you had done? And give me the years and why you wound up having it done. Next question winds up being, well, do you have any allergies that maybe will cause you to die or get a rash? Next one is, I want to review the symptoms. Well, tell me about your heart. Do you have chest pain? Do you have palpitations? Do your feet swell? Do your hands swell? Do you have asthma? Do you have a cough? Do you pee a lot? Do you poop a lot? All different things that you want to go through. Tell me about your social history. Do you wind up smoking once a day, twice a day, every day? Since you were 10, when did you stop? How about drinking? How much drinking do you do? Is it too much? Is it too little? What about the drugs that you're using? Did you used to drugs in the past? Are you still using drugs, and how much? And then there's a 4-line little thing that goes, by the way, what's your family history? Which you can maybe put down 2 relatives or 3 relatives. When we talk about genetic testing now, we're not only talking about finding out about mom and dad and brothers and sisters, we're talking about 3 generations. We're talking about aunts, uncles, nieces, nephews, cousins, grandparents, and great-grandparents. And this is what we have to come across, and this is what we wind up teaching, is how to identify somebody. No matter what reason they're there, there's no reason we can't get that family history in around 3 minutes or less. We usually don't go by what the person puts down on that form because we know it's going to be inaccurate. And that's one of our key things. When we wind up doing the genetic testing, there are certain standards we have to include. One of those is, if you're going to do the test and somebody has it, what's the incidence of being positive for it out of the general population? If you have it, what's the risk you have? Because that's important to know. Do I have a certain risk for a different type of cancer? And then if I have that risk, what can I do about it? Is there screening that I can pick it up early and maybe change the course? Is there risk reduction surgery that we have to talk about to prevent the cancer from happening? So these are all issues. Then who else would be at risk of the family? When we test, we have to make sure this is not a secret. This is for everybody to know. It's important that if you have it, did you know that all your siblings are at a 50-50 chance of having it? If they have it, do you know that all your children are a 50-50 chance of having it? Did you know if your aunt had it, all of her children are a 50-50 chance, and any of your cousins may be at a 50-50 chance? And then you need a conversation. Is this going to affect your health insurance? Is it going to affect your life insurance? And how is it covered with your insurance? So these are all major issues we have to do, and also do very quickly. Because remembering, we're identifying these people, and they may be there for a gallbladder operation, or they may be there for breast pain, or they may be there for an ovarian cyst. And we want to cover these things in maybe around 10 minutes, 15 minutes, and it's possible.
Thanks. So Anna, so Stephen's talking about the importance of family history in the case of breast cancer, hereditary breast cancer, but that is not so relevant to your situation. So can you tell us a little bit about Nicole and when you got her tested and how that has affected you?
Sure. Nicole's 6.5 now. She's the youngest of 4, so mom's instinct kicked in pretty quickly in the hospital when I saw her and saw some things that were not as I had expected. Physically, 100%, APGAR, top marks, etc. Suck swallow a little off, musculature a little off, and what does this mean? And you carry on because everything's fine, her APGAR was fine, etc. She had delays, not failure to thrive, not anything significant, a little slow on her milestones, not sitting up when expected. And we fortunately had a phenomenal pediatrician who, in conjunction with me saying, totally different than my big 3 kids, they were, superstars and did everything right when they were supposed to. Nicole's not doing that. What's up with this? And she said, let's go right to the chase and let's do a blood draw and let's test and see what we can come up with. There could be some things that we can do things about. There can be some things we might not be able to do anything about. But this is going to be something that's going to help to know, and whether it's just ruling out or actually getting an answer. So we were fortunate. It probably was about 14 months, 15 months when we actually got the information back from Children's Hospital here in Oakland. We live just through the tunnel in Orinda, and were able to very quickly tap into an international group, all of 600 people internationally today, so a tiny, tiny group, but people we could turn to and say, what are you doing if, what should we do when? So it gave us an extended family. This wasn't something my husband was familiar with or I was familiar with. We didn't contribute to this circumstance. So it was all new to all of us. And along with what Deborah said, finding out who your support system was and who could accept and understand and grow into this situation with you was really key. A teeny bit of history on Phelan-McDermid syndrome, when Amy mentioned that there wasn't a name for it early on because it was just the 22nd chromosome, and they had used certain types of chromosome tests to identify that deletion and had all of 15 cases identified in 1992. It's still considered to be vastly underdiagnosed. You don't necessarily know to even explore that. And like the film said, between cerebral palsy and mental retardation, a lot of global catch basins that were used for people diagnosed. The numbers gradually climbed, and the network and the communication and our exposure is climbing. So we had at our most recent conference this past July, 110 families attended, about 450 people. So we had someone from India, from Costa Rica, from the Philippines, from Ireland, all coming together to share and support each other and see each other and know how similar or different our circumstances were. And it's been a tremendous, tremendous support to have that and to know specifically what Nicole's diagnosis is.
Thanks. So we've heard about some of the impact of the information on you guys. I wanted to sort of backtrack a little bit first, because a lot of what they've been talking about here at Berkeley is not the impact of a test, but whether to get the test. Should you get the test? What can this information do to you? How does it? How should it be delivered? So I wanted to ask each of you to talk a little bit about that. Katie, did you have qualms about getting the test? Were you encouraged to get the test? What was the situation when you did get it?
When I was going for the test, I couldn't even imagine going for a test and not knowing what you're testing for. I went in there knowing that I wanted to be tested for Huntington's disease. I was strongly discouraged from testing. I I mean, people said there's nothing that you can do about it. People said that I was young. It was 2004 that I started going for the testing process, and I was 23. So they kind of said, you know, you have this whole life and everything. But to me, it was, well, you know, it's something that's inside of me, whether I know or not. It's something that I can mentally and physically and financially prepare for. And to me, that made the difference. You know, that was what, you know, I wanted to be able to do. You know, I mean, at the time, I never thought I'd be doing this or, you know, talking about it or anything. I wanted to do it for me so that I can be prepared for my future. I mean, ideally to test negative and not have to worry about it. But, you know, and unfortunately testing positive and, you know, trying to plan for it, which, you know, no matter what I wanted to plan for when I was going through the testing process, you know, I mean, I don't prepare as well as I had planned to. Instead, I kind of just live for today and do whatever I want. But, I mean...
Okay. I just wanted to mention, you guys, we're going to take questions from the audience, too. We're going to talk a little bit amongst ourselves for 10 or 15 minutes, and then there'll be plenty of time for questions, and I hope that you will have some. But I wanted to ask Deb the same question. Deb, was it ever an issue for you about getting the test? What made you decide to go get the BRCA test in the first place? Oh, we can't hear her.
Did I lose my volume?
You're back.
Okay. So every time I'm on a panel with Katie Moser, I feel like I shouldn't even talk because, Katie, you're incredible. And I can't even imagine testing for Huntington's disease. Like I stand in awe when I talk to you. But I feel like for me, the decision was so clear-cut and obvious. You know, if you know that you're at risk for lactose intolerance, for example, you just don't eat cheese because you know what it's going to do to you. I feel like my gene is similar to that in that I knew exactly what I needed to do if I tested positive. I knew that if I tested positive for the BRCA gene, that I had an 87% lifetime chance of getting breast cancer and about a 50% lifetime chance of getting ovarian cancer. And so it was very obvious to me that if I tested positive, I would need to do something to reduce my risk of getting cancer. And those things were very clear cut. As a medical professional, I knew that I could do increased surveillance of my breast and ovaries with mammograms and ultrasounds and such. Or I could choose to have risk-reducing surgery, like a mastectomy and like having my ovaries removed. And by doing those things, I could reduce my very high risk of cancer down to an astonishingly low risk, on the order of 1% for both breast and ovarian cancer from doing those surgeries. And so to me, it was kind of a no-brainer. Unlike lactose intolerance, where it's very obvious that you're allergic and that you can't tolerate dairy products, this was not something obvious. I knew there was a 50-50 chance that I had this mutation. And so to me, there was no question that I needed to test for this mutation in order to decide what the proper course would be to manage my risk. Not all genes are like this. You know, some genes don't tell you a clear-cut yes or no, this is what I have to do. Some genes, I think, are a lot trickier, like Katie's, to figure out how exactly you're going to handle the knowledge. In my mind, knowledge was power. My knowledge of my disease empowered me to make some incredibly tough decisions, but decisions that I knew would save my life. So I guess I didn't have any qualms about getting the test. Although I will say that in the process, I don't think I personalized the fact that I could test positive. When we first started testing in my family, I actually was the one who encouraged my mom to get tested. And I thought I was helping my family because I was helping everybody to figure out what their risk was. not really understanding what a personal impact that was going to have on me. And it wasn't until I actually got the call from my doctor saying that I should come and talk to her about my results that I realized, it dawned on me that this was something I was going to have to face on my own as the first person in my family that ever had the privilege of knowing in advance that I was at risk for cancer. And so I think while the decision to do the test was very quick and very gut level, I have to do this, what transpired after that took a whole lot more thought. And like Katie said, I probably did the test not fully understanding what all it would bring into my life.
Stephen, are all of your patients as certain as Deb about getting the test when you describe the possibility to them and their risk?
Well, at the beginning, it's something that they're very unsure about. It's one thing when you know that there's a mutation in the family, because when there's a 50-50 chance that somebody else in the family is going to get it. So if your mom has it, it's a 50-50 chance that her children are going to get it. Or if the grandma had it, it's a 50-50 chance that her children are going to have it, and the ones that do, her children may be affected. We try to identify the unaffected people that we don't even know in the family if there is any. We just go by their family history and the risk factors. And when I present this to people, the way I present it is by not knowing, if you take all breast cancer, what's the risk of having the mutation? And in reality, it's maybe only 7%. 93% of the people that we're going to check are going to be negative. But what I tell people is that if we look at your family history, I have several people, or a lot of people, whose family history is worse than yours, and they're negative. On the other hand, I have families that are much better regarding their family history of breast and ovarian cancer, but they're positive, and you can't tell. And we go over the risk factors, and what I wind up telling them is that I'm not testing you because I think you have the mutation. I'm testing you because you have risk factors, and that's the reason to have the testing done. Matter of fact, until you say that it's only 7% chance that you really wind up having it, the majority of people will sit there and assume that they have it. And they will start thinking, oh my God, I'm going to be getting breast cancer, I'm going to be getting ovarian cancer. I don't know if I want to know anymore. And until you let them know that in reality, the odds are very low that they have it, but we have to test you to know what your real risk is. Is it maybe 8% by the age of 70 in the normal population? Is it something maybe between 20 and 30% with family history? Or it is as high as 87% by the age of 70. We want to know what your risk is, and we want to find out what it is, and the only way to find out is to test. And actually at the breast center, around 99% of the people will have the testing done that day.
But Deb, I just want to ask you, because that's not, that some members of your family would have been in that 1% that don't get the test on that day, right? I mean, that's not persuasive to everybody. There are people who are at risk who decide not to, right?
Yeah, you know what? It's interesting. On the one hand, I agree with you, Stephen. I think that it's great for people to have that knowledge. And personally, I feel very privileged to have that knowledge. But not everybody wants to know this information. And I have to say, when I first realized my test results were positive, I just figured, well, everybody's going to share in this knowledge. Everybody's going to want to know. And even within my very own family, there were 3 women in my family who absolutely did not want the knowledge. And in fact, they were upset with me for bringing it up to them. And in fact, Amy, I think you were there the night before my surgery when I was having my mastectomy, one of the hardest decisions in my life at the time. My aunt emailed me the night before my surgery and said, you're making the biggest mistake of your life. You're about to mutilate your body. You still have time to say no. You don't have to go through with it. And, you know, she's from a perspective of she doesn't want to know her risk. She would rather be blindsided by cancer than to have a surgery that would reduce her risk that she finds to be mutilating. And so, not everybody wants to know. And I've found this to be the case as I test patients in my office. There are certain people who are knowledge people. They want to know everything about their risk. They want to do something about it. They want to be proactive. But you know what? There are other people who really don't want to live with that fear. They would rather live in blindness to the fact that they might get cancer than to have to think about it and make decisions around it. They would rather live for the next 20 years not thinking about cancer, but instead live a full life without having to worry about mastectomies and dating and all this kind of crazy stuff that I've had to work through. Instead, they would rather live a full 20 years or so and then suddenly be hit by it and die. And honestly, there are people who that's their perspective, and that's not wrong. It's a personal decision. And I always tell my patients, this information is there, and if you want to take advantage of it, you can. Personally, I wanted to know that information because I felt like it could change my life and potentially save my life. But not everybody wants to know that. And I have really come to respect people who make a different decision than I did.
And I want to get to you in 1 minute, but I just want to ask Katie to talk about your family members who might have felt differently about getting tested, especially maybe you could talk a little bit about your mother and how you differed from her in your decision to get tested.
Okay. Every child of a person with Huntington's disease has a 50% chance of having the gene. I tested, it was my grandfather who had Huntington's disease. He passed away in 2002. I was testing in 2004. I tested without my mother knowing if she had the gene or not. So technically my risk was 25%, but I saw symptoms in my mother, and I saw symptoms in my mother for a long time. So by my testing positive for the gene means that she has to have it. Of the 6 in my mother's generation, 2 of them have tested. One tested positive and has symptoms of the disease. One tested negative, and one has not needed to test because she is progressing through symptoms of the disease. So, we don't need to know her genetic status because we know she has the disease. But, and then there's my mother. And then the other 2.
Who still has not been tested.
Who still has not been tested, but is symptomatic. And then the other 2 are just completely against it. And when I went through the testing process, it wasn't my intention to tell. I actually kept it to myself and my family. Like I said, I told my friends, I told coworkers, I started to get involved with HDSA, but I didn't tell my family because although I wasn't speaking to my mother for reasons that you could read about in the New York Times article, I wasn't speaking to my mother, but I knew some of them were, and I didn't want them to use the information to help themselves or to hurt her. But eventually, it did have to come out in order to protect somebody else, and I did come out with my testing positive for the gene, so then she was now aware that she had it. And then I started talking to Amy, the reporter. My whole family was, all aware of the New York Times article. They all spoke to Amy, the reporter, and they were all aware that it was coming out, but, they got very angry after I told my story in the New York Times. They got very angry again when I went on The View, and they got very angry again when, whatever happened next. They're not ready to deal with, the idea of the disease affecting, their generation, and I guess in a way the disease affecting the next generation.
Yeah, it's just really interesting how this kind of information can ripple through families, and it was fascinating to me because I'm, like Deb said, I'm a knowledge person, so this kind of information is information that I want. But many people, like my father or other people, there are just people. Some people don't want the information. And so, Anna, what about you? Was there any hesitancy for you in going to get Nicole tested, or did you just want to know?
I would put myself in the category of a knowledge person, and my husband as well, and knowing that here we have a 14-month-old who has ideally decades and decades in front of her. If there's something that's going to impact her life expectancy, we'd want to know that. If there's something we could be doing now proactively, therapeutically, medicinally to help her get past this developmental delay, or maybe she's always going to have delays, but what can we do to enhance her life and to know? So there was no hesitancy at all, and it has paid off in volumes for us, knowing not only from the insurance perspective when we're filing and exploring different therapies to have a diagnosis, when we're working through her schooling programs and being able to know and connect with these other families about what augmentative communication devices she can use as a relatively nonverbal child, or occupational therapy-wise, what she can use based on seeing these other 600 families and what they've worked through. Some as old as 42 is the oldest diagnosed individual, and then now it has been diagnosed in utero and can be diagnosed immediately if you are anticipating. There is occasionally times when it's hereditary, if there's a balanced translocation in a parent that becomes an unbalanced translocation in the offspring, or if there's a mosaicism in the parent that is not causing any impact to the parent and then is carried down. But again, in our circumstance, we had no reason to believe that we had contributed, partly having 3 healthy children, typically developing children, and then Nicole with these developmental delays.
And was there anything for you or in other parents that you know about sort of the certainty of the diagnosis that was hard to deal with when you got it? Or was it just you were really happy to know what it was? I mean, I've talked to other parents who, it's such a journey to try to figure out what's going on with their child, and then they get it, and it's hard because it's not exactly the answer, or I don't know.
And I think I had my own journey with it, as there's stages of grief, et cetera. My instant reaction was something that shocked the pediatrician when she called, and it was relative because we had had a tragedy in the neighborhood where a person lost a child. And so it didn't really matter what she was going to tell me because Nicole was there sitting on my lap. It wasn't until later when I realized the magnitude of, and she was progressing, but then in later meeting other people whose children were totally nonverbal or not ambulatory or not self-feeding or different things was terrifying, and not knowing how she was going to progress through those. We're fortunate that she's ambulatory, she self-feeds, she's verbal, she's made great strides, but had we not known her diagnosis at 14 months and not been able to do all the things that almost 24/7 a parent is willing to do for their child to help them, she wouldn't be able to do what she's doing. Right. We've also taken the approach that we can't do this alone as a couple. We can't even do it alone as a couple with grandparents and siblings, but we need everybody in our town and everybody in our school district to know. So we've been out there doing presentations to the kindergarten classmates and first grade classmates so that they can embrace her and they can help be her friend and help her along through what can be an ugly society if people don't understand or if people are afraid. And so we've really taken the role of education, not only of our family, but of anybody who engages and interacts with us.
Right.
Amy, can I say one more thing?
Yeah. Yes, go.
I think that it's interesting because as both of you have talked, I think our main focus is typically on when you do a genetic test, what's the personal implication and what's the implication for our family. But I think the piece that often is overlooked is what is the public implication of having a positive gene test. I was so struck by this. About a month and a half ago, I sat on a panel with another BRCA mutation carrier who is about 15 years older than I am. And when she was one of the first people to ever have a diagnosis of BRCA. And when she found out how high her risk was of breast and ovarian cancer, she decided very early, before anybody was doing mastectomies for this disease, she decided she was going to have a mastectomy because her risk of breast cancer was so incredibly high. And at that time, nobody really talked about this disease, and nobody had felt like they could be open about it. And in order to get her surgery covered, her surgeon had to tell her insurance company that she had a hysterical disorder, and that the reason she needed a mastectomy is because psychologically she was so sick that if she didn't have this mastectomy, it would be harmful to her psychologically because she was essentially insane. And hearing that story was so shocking to me because I realized how much change there has been in the public perception of genetic disease. When I went through my genetic testing, it was a no-brainer. We called the insurance. We said, you've got a BRCA mutation. They said, okay, we'll pay for the surgery. And, even though I mentioned there was some backlash in the public with certain personalities, in general, the vast majority of the people who had heard about my testing agreed with my decision, supported my decision. And I guess it really brings up to, in my mind, the importance of the public nature of genetics and how, we really have this sense that based on our test result, we will be perceived in a certain fashion. Even though that's not necessarily the case, there's a certain sense of historically there's been sort of stereotyping and prejudice against people with genetic disorders. And I think that really still plays into the psychology of genetic testing. I don't know if either of you who've gone through genetic testing for yourself or your family, if either of you feel that way, Anna or Katie, but there is more than just the personal and family implications. There's a lot of how is this going to affect the way everybody looks at me?
I'm really glad you brought that up because Anna was just, we talked about the ugliness of society, and I wanted, maybe if either of you want to respond, Katie, specifically with Huntington's disease, you talked about the stigma and people not talking about it for many years, and they're beginning to talk about it now, and you are part of a generation that I think is beginning to test more earlier because of the little bit of changing around that. But do you think it's changed a lot? Do you think it's changed enough? Where are we at with that?
In terms of the decision to go for testing?
No, the stigma. What Deb is talking about is that there's still one reason people don't get tested, and one reason that this is sort of like a serious thing. That it's not when it's not just about lactose intolerance. That that this is that there's discrimination around people who are perceived to have genetic disorders, and how that plays into the decision of people to get tested.
I think for Huntington's disease, it's, I think, I tested for the gene. I have the gene. Everybody in here has the Huntington gene. Your bodies are all making this protein called Huntington, and whatever it does, your bodies are doing it. You're using it up. I have a mutation. So mine is making this mutant Huntington that is kind of like overcooked spaghetti and is sticking together. I'm not a doctor or a researcher. It's happening. It's happening in me. I don't have any symptoms, but, I don't know when they're going to start. I don't put it on a job application that I have the gene for Huntington's disease. I don't have it in my medical record. I don't want to pass it on to my kids, and I opted to have a tubal ligation so that I didn't have to go through hormonal birth control, because I do want to have kids someday. I just don't want them to have the gene. And when I went into the doctor and asked her to do the procedure, she was kind of like, no, you're at risk for Huntington's disease, but you're not going to get it. And I said, no, I have the gene. I will get it someday. And I made her put down, some other reason as to why I was having the procedure so that, it didn't say Huntington's disease, because, I don't want to get turned down for insurance someday. But at the same point, coming out and talking about it all the time. If you Google me, the New York Times article is the first thing that pops up. So I do tend to be upfront about it in my personal life. My friend Colleen and I were talking about it one time, and I think this is actually in the article that I never really dated, like, ever. But we talked about that if I were dating and I made it to a third date, like, that would be something, and that would be the date to tell the person that someday I'm going to have Huntington's disease.
Speaking of, did you want to say something?
Yes, well, one additional thing that I think we also have to remember, particularly with the BRCA mutation, is that's not the only mutation that's out there that causes hereditary breast cancer or hereditary breast and ovarian cancer syndrome. So when we wind up telling somebody that they don't have a mutation in that BRCA gene, it doesn't mean that their risk is very low. As a matter of fact, we treat some individuals that have such a strong family history, we give them the same options as somebody that would be considered BRCA positive with the mutation. So we have conversations that would wind up saying, well, you know what, woo, there we go, that you do not have the BRCA mutation, but you still have a very strong family history. And so that you're still at some risk, and that doesn't go away. But there are some patients whose family history is so strong, working, not working, where the family history is so strong that we give them the same options. And I let people know, just because you're negative doesn't mean the BRCA mutation is the only one that's out there. There are still some that we don't know about. The BRCA mutation may make up maybe 85 to 90% of the reasons for hereditary breast and ovarian cancer syndrome. So that's important too when we speak to these individuals. It's not 100%.
Thank you. I really want to open it up to questions, but I do want to ask one more question of Deb. Katie mentioned dating. Deb, you said that things had changed, all changed, everything had changed, and everything had changed for the better. But it wasn't like clear, like instantly changing for the better, I don't think. And I wondered if you could talk a little bit about, Deb did recently get married, but not to the person that she was holding hands with in the article that I wrote, in case anybody saw that picture. So can you tell us a little bit about what happened there?
Sure. You know what, I think it's kind of a telling story, and I always tell people that I feel like knowing my gene status was the great sifter of men, because it really allowed me to see who really was the kind of person that I wanted to be with and who was not. Actually, I have a history of dating all people named Jeff. And so the guy I was dating at the time was named Jeff. And I actually found out very shortly after my surgery, it was a 6-week recovery, and through that 6 weeks, I didn't have the time to spend with the person I was dating that I was accustomed to. And, certain things transpired, and it came to light that he had been cheating on me while I was recovering from my surgery. And when I confronted him about that, he said to me, I didn't think I could be attracted to you after your surgery, but now I think I can. And at that point, trying to redeem himself. And at the time I said, obviously I was hurt by that, and hurt by the fact that he couldn't see past my physical appearance or what he thought my physical appearance was going to be. And at the time it was really hurtful to me. But after I came to terms with what exactly had happened, I realized this isn't the hardest thing that will ever happen to me. In life, people die. Babies are born with horrible disorders. People are disabled. There are a lot of horrible, awful things that can happen to a person. And if he couldn't stick with me through something so minor as a mastectomy, obviously this was not the kind of person I wanted to spend my life with. And it became even more clear when I started dating the current Jeff, the one that I'm married to. After the third date, Katie, I think you'd appreciate that, because it was on the third date that I actually shared my genetic status with him. And at the time, I didn't really know what he would say. My only experience in dating was with the Jeff who dumped me and cheated on me over my mastectomy. And, I actually shared with my husband, Jeff, at the time. I told him about my story, and I told him what my risk was, and, that this is something he needed to know about me. I was on call that night, and I left him at about 5 o'clock in my scrubs, went over to the hospital to start my shift. And about 4 hours later, I got a text message from him. And I'll never forget the text message, because it said, I went home and I read the article and I watched the video online, and I think you might be the coolest person I've ever met. I can't wait to see you again. And so I know that's a really sentimental story, but I think it's very telling of how you really can see the genuine character of a person when they are confronted with a potentially challenging issue about you. I think it really is telling of their character, and for me, that made all the difference, knowing that he could handle that. Not only could he handle it, but he could appreciate the beauty and the strength that that information had given me and brought out in me. So I hope that answers your question.
Yes, thank you. Okay, and with that, I would like to open it up to questions from the audience, if anybody has one, or we can continue talking up here. Oh, yeah. Can you go to a microphone? Do you mind? Do you mind going to a microphone? Oh, you have one? Okay. Deb can't hear you unless you're on a mic, so if it's for all of us, it's important.
I have a question for all. When do you put it on a job application that you have something like this? And the bigger part of the question is the cost, just paying for all this information, this medicine. When do you put it on a job application?
Can I answer that?
Go. Yeah, why don't you go first? Take that first.
So I think it's amazing, and should be pointed out, that about 1.5 years ago, Congress passed the Genetic Information Non-Discrimination Act, which is called GINA. And GINA makes it really a federal offense to discriminate against someone for a job or for medical insurance because they have a genetic disorder. So I think the answer to your question is you never have to put that on a job application, because it's none of that employer's business whether you have a mutation of whatever kind that is. I'll let somebody else answer the other part of the question about the cost.
I know the cost, at least for the BRCA mutation, is around $3,400 for an entire sequence of the DNA, that once you wind up identifying where the mutation is, you only have to do a site-specific test that costs around $440. Fortunately, probably around 90% of the insurances cover the entire cost of the test, with maybe 5% having a copay and 5% not covering it. As a matter of fact, the interesting thing is that if somebody has Medicare and they haven't developed the cancer yet, they can't be tested, no matter what their family history is. It turns out that a person can also find out exactly what the cost is, because what will happen is before the test is run, an individual can sign a piece of paper and say, I want to know the exact cost, and the company will call them up and let them know what their copay is and deductible. So they will know exactly if there is any cost. And they can even spread that out over 25 months with no interest if they wanted to do it. One of the things I do tell people, though, is that particularly in an unaffected individual, your risk is, and we don't know anything about the family, your risk is only maybe 7%. The odds are you don't have it by 93%, so please, if this is something you can't afford, don't pay for the test. And there are usually other relatives in the family that we can try to figure out who else to test, particularly one that maybe had the cancer. Because if you test the person, the individual in the family that had the cancer, whether it was breast or ovary, and they are negative for the mutation, you know everybody else is negative for the mutation, as long as you don't have the father that has a strong family history and you're testing mom. So if you can test that person, you don't have to go after these unaffected individuals. So that's very important too. You can save a lot of money by going for the person that's had the history of cancer, see if it's in the family first. And if it is, then you only have to do the site-specific mutation.
I think, I mean, we all celebrated when Gina was passed, and, you know, we're still seeing how it's fitting into everything. But, I mean, my current job, I left the nursing home 2 years ago, and I work for the pharmaceutical company that has the first FDA-approved treatment for chorea associated with Huntington's disease. So I travel around the country, and I talk to support groups or HD education days or physicians' offices, and I share my story about testing, and I talk about, you know, the drug company and their commitment to the HD community. So I got my job because they Googled Huntington's disease, and there was my name. You know, they called me, and I was like, you know, I have a job. But it kind of seems like the next, you know, step in my life and in my HD life. But you know, I'm an occupational therapist. That's what I went to school for, and you know, that's what I love to do. But with Huntington's disease, there's psychological symptoms, there's cognitive symptoms, and there's physical symptoms. Someday I'm going to slowly lose the ability to take care of myself, to wash myself, to feed myself, to dress myself, to, you know, play games or, you know, have a conversation. And as an occupational therapist, it's my job to keep people independent. You know, it's my job to help people to be able to do those things. And I know that someday I'm not going to be able to do my job. So, you know, what I look for is, you know, someday I'm going to have to tell somebody that, you know, I have the gene and, you know, I have the disease, and hopefully maybe I'll be able to do some, like, teaching some classes or something to just keep active in the working world. And as for cost, I mean, it varies throughout the country, but my testing, I just had to pay for the blood test, and it was $287. And I saw a therapist at the same time. And for cost for medications and everything, there's nothing. I don't have symptoms. There's nothing that I could take other than just, you know, trying to be healthy and not get other things. So that's me.
I don't know that
Did
I have
you?
a comment.
Okay. Is there another question?
A short question for Dr. Lindner. I'm wondering, since when you see patients who are at high risk for breast or ovarian cancer, and if they're not a knowledge person and they don't want to know, do you ever find yourself wanting to look them in the eye and say, look, let me tell you my story, and this is why you should get tested, and so on and so on?
I do. I'm very upfront with my patients. I think no matter who you talk to in the medical field, there's always going to be a bias. And I tell my patients that. I say, you know what, if I send you to this surgeon, they're going to tell you, I want to do this kind of surgery. That's the best surgery. And if I have to send you to this person, they're going to say, no, you shouldn't have surgery. That's the worst thing you can do. I mean, everybody has a bias based on whatever they've read or their personal experience or whatever it is. And so I always tell them going into this conversation, I am BRCA positive. And so I come into this being able to share with you my experience and my personal decision-making on this topic, but I am not the same as you. And so I want to share my information with you, and I want to share the medical information with you, but I want you to know that whatever decision you make, I support you 100%. And, you know, there are people who, I know how much it can change somebody's life. I've tested people who test positive, and when I do their first screening mammogram 10 years earlier than they would have ever had a mammogram before, and I find an early cancer, I know that if I hadn't done that gene test, they most likely would have had a fatal cancer by the time it would have been otherwise detected. And so, yes, I see the benefit it could have, the even potentially life-saving benefit it could have to all of my patients. But I tell them, you know, as much as I see this as my analogy is always that, you know, there's a train coming, and whether you know it's coming or not, it's still coming. And when that train comes, do you want it to hit you, or do you want to be able to step off the tracks before it comes and do something about it? And, you know, that's definitely how I see it. I see it as something that potentially you could avoid a fatal cancer by knowing that information. But I also completely respect people who decide they don't want to know that information. I think for cancer syndromes, it seems so clear-cut. It seems like, you know, if you just would learn about this information, you'd be able to do something to stop cancer from happening. I don't think it's quite as clear-cut in other syndromes. I think especially when it comes to something like Huntington's disease, it becomes a much more personal decision, and how you're going to use that information becomes a lot more subjective. But I really don't think it's fair to tell every person who could potentially be at risk for any genetic syndrome that they have to be tested. And I think as much as some people with a family history of Huntington's disease would say they don't want to know, I think the same goes for BRCA, and the same goes for Lynch syndrome, and the same goes for any syndrome. There are people who don't want to know their genetic risk, and that's okay.
Looks like we have another question. Go ahead.
Yeah, I had a question. I know that Katie had mentioned or touched on it slightly earlier, but perhaps if you could elaborate on it a little bit more, that would be great. I just wanted to know, what implications does the test result hold for insurance? And is there, you know, circumstances which that information needs to be disclosed? And, you know, further, what has your experience been in that regard?
I mean, for my insurance, with my current company, I'm covered under a group plan. So, you know, it's they don't ask those questions and they can't discriminate. And with GINA, there's...
Which is the Genetic
Information Non-Discrimination Act. You know, it's written in there about not discriminating against insurance, but not like long-term care insurance. So it's, you know, it only covers for certain insurances. And a lot of the questionnaires and the review for when you're going through the process of getting insurance, a lot of it is starting to ask, you know, and maybe it's because of all this awareness that we're doing, but a lot of them are starting to ask specifically for Huntington's disease. And technically you're not supposed to lie. But I've heard that if you do lie and you don't claim, you know, if you don't claim that insurance for like 2 years, there's sometimes some kind of waiting period that if you are out of that waiting period, they can't go back and take it away. But as I mentioned earlier, you know, my whole goal for planning financially for the future has not happened. So I've not looked into insurance. I'm really, really, really banking on a cure.
Great, thank you.
But the Genetic Information Non-Discrimination Act that Deb mentioned is considered a real milestone in terms of protecting people. It does prohibit employers from discriminating against people who have had genetic tests and from health insurance. But as Katie said, it doesn't cover long-term care. So that's a pretty big issue for people who need long-term care. And also, it hasn't really been tested yet in the courts. And so we'll see, you know, what happens with that bill, how protective it really turns out to be.
Amy, the other thing about that bill that I find really interesting is that while GINA protects you against health insurance discrimination based on your specific gene, it doesn't prohibit discrimination based on your family history, which sounds so ironic because a gene is part of your family history, but it's almost like they give lip service to the fact that you can't discrimination for the genetic test, but you can have discrimination. For example, if I am asked on my medical insurance, you know, how many people in your family had breast cancer? Did your mom have breast cancer? You know, have you ever had surgery? That's a question in my health questionnaire. And so it is an interesting thing. While in effect there's no discrimination against genetic testing, there's still some room.
Right, they leave a little loophole there. Are there other questions from the audience? Yes? Do you mind going to a microphone? Yeah, thanks.
Yeah, I'm more interested in the future of this. I think this is more of the tip of the iceberg. With DNA sequencers becoming faster and more inexpensive, how do you foresee the future? Do you see a world where individuals will be able to have their own sequence and through perhaps a software or an algorithm figure out all their genetic traits? And how do you see the future, like 10, 20 years from now?
Well, just one thing that's going on now, as far as hereditary breast and ovarian cancer syndrome, and even with electronic medical records that are now going in, some of the risk factors regarding family history are being put in, and a red flag will pop up as far as genetic testing that may be required for a certain syndrome from family history. There are even mammogram centers, radiology centers now with electronic recording will wind up getting family history with risk factors. So what will wind up happening is when a physician goes to read a mammogram, that in the mammogram report, that when it comes up, it will say high risk for hereditary breast and ovarian cancer syndrome. And the question is, what do you wind up doing, with that? What does the radiologist do with that information? Which is very interesting because you need sort of an informed consent. Should the radiologist contact the primary care doctor, and does he necessarily know what to say? Do they wind up having somebody from the cancer center come down and talk to the woman? So it's definitely getting out there through electronic medical records what the risk factors are. I don't think anybody's ever going to be able to walk up and just say, I'm going to be tested for this without a risk factor. Because again, you're still dealing with the cost of medicine. As much as people may want to know, if you don't have the risk factors, nobody's going to test you. But it is the tip of the iceberg now, where it is being included in medical records, looking for red flags for people that at least a conversation should take place about testing.
Well, I mean, and I think you're right that it's the tip of the iceberg. I think that, if we can be tested, if you can know your whole genome sequence for $1,000, which actually might even be available now, the sort of the part of what we've been talking about here is, do you want to know? And I think maybe the luxury of that decision is going to go away. I mean, we will know because it's just going to be cheap enough for us to know. Like we can, know if you have high cholesterol, you just know. So, and what we have to deal with as a society is how do we deal with that knowledge? What do we do with all of that? Or do we say, there are certain things, you're going to know, doctor, but I don't want to know. I mean, that's part of
one of the interesting points we were just talking about dinner is how if you know something early, maybe you can affect your diet, you can affect your health habits early on to maybe prevent a certain outcome, whether it's high cholesterol or high blood pressure or heart disease. When you start finding it doesn't always have to be cancer or something like that, maybe in the future we will be able to do something like that where people can start working on it ahead of time.
Right. We've one more question. Go ahead.
I know that you, Katie, touched on this a little bit earlier, but I was wondering if you could talk about the role of genetic counselors or therapists and how you see those roles increasing over the next years as more and more people get genetic testing.
When testing for Huntington's disease, our national organization has like a testing protocol that if you go to one of their centers of excellence, which is, a center, a hospital, a group of physicians, a group of practitioners who know Huntington's disease, in their protocol, one of the first people that you see is a genetic counselor or a social worker to talk about why you want to be tested and what you're going to do with the results. Because testing is not for everybody. Some people, I'm lucky to have had a very positive experience with finding out my results and being able to move on. But some people have a very difficult time with finding out that they have the gene. And some people have a very difficult time with finding out that they do not have the gene. Whether they're having what they feel are symptoms, then they start to think like, okay, well, what's wrong with me? Or they start to think, it's kind of like a survivor's guilt. Well, why not me? Like, what am I supposed to do now? So it's it's encouraged to go see a therapist or a counselor after that, just to continue to work through it, after the results. And also in the HDSA protocol, when you go to get your results, whether they're positive or negative, and no matter who you are, they want you to go into the clinic so that you can receive the results in person rather than over the phone. So, I mean, it's been, I think that the role of a counselor, as an OT, I don't know, I have a mental health background. I think everybody should be in therapy. But I think it's really important to have somebody to talk to. Unfortunately, sometimes, the genetic counselor, whoever has their own ideas. She was one of the people who discouraged me from getting tested. When I went into the clinic, she told me that I was sometimes, the wanting to get tested is just a cry for help. And I just looked at her and I said, no, it's because I want to get tested. I want to know.
I think,
but yeah, no, go ahead.
Yeah, I think there are going to be certain areas where you do not need the genetic counselors, where there will be cases that are very straightforward, that a physician can look at a person, get a family history, and say, okay, I know what I have to do. But they're not geneticists, all right? So that there are going to be people with a bizarre family history where you just have to go, I don't have a clue what's going on here. And you contact the genetic counselor, you contact the geneticist. There are going to be some physicians that will want to do it in the office, and there'll be others that will say, I'll identify them, but I'm going to send them to the geneticist or the genetic counselor. I think either way is perfectly okay, as long as we're identifying people at risk and talk to them about whether or not they want to have the testing done, and go through sort of the entire protocol of informed consent. But I think there will always be. Nobody's, at least as far as surgeons, OBGYNs, medical oncologists, nobody's a geneticist. Can they talk specifically about what they deal with? Absolutely. Do they have to see a geneticist or a genetic counselor? Absolutely not. They don't have to. I think the physician is capable of doing that with certain areas, but it depends also what that field the physician's in as to what he's an expert in. So there'll always be genetic counselors, but I think a lot more, as I had mentioned before, a lot of societies are starting to put that on the back of physicians for at least the identification of these patients.
And I think also there is the possibility of getting information without a genetic counselor or a doctor mediating, and that may increasingly be the case. I mean, ideally, you might have it all interpreted for you by a professional, but there aren't enough professionals to do that. So that's one of the reasons why it's important to understand what it all means, and I think to have discussions like this, and maybe that's a good note to end on. I really want to thank our panelists for coming, and for Berkeley for having us. I appreciate it.
On behalf of the university, I'd also like to thank our panelists and Deb remotely, and especially Amy Harmon for contacting us and being interested in what's going on here at Berkeley and contributing to the education of our community and our students and the public at large. So thank you all very much for coming, and thank you, panelists.